I think we'll get the ball rolling, shall we? Okay. So firstly, my name is Enda Guinan and I'm the Digital Communications Manager at Sarcoma UK. We're really happy to see so many of you turn up for this, which is the first in our series of webinars. You're all extremely welcome, and I hope you'll find the evening and indeed the whole series to be useful. We have a few bits of housekeeping to attend to before we get to the main event. Firstly, the webinar is being recorded and we will share it on the website a little later this week. Because it's in a webinar format, your details won't be on the recording. We actually can't see you, although you can see us. We will have some time for questions later. So if you wish to ask a question later and we turn on your video, you will be on the recording. So if you would prefer not to have that shared with the public after this, then just let me know and we can edit you out. So feel free to take part fully tonight, but let me know afterwards if you prefer your part to be taken out of the recording, and we'll put the details of that into the chat. So your host this evening is Helen Stradling, who is the support line lead and sarcoma specialist nurse. And in a moment, I'll hand over to her to lead us through the webinar. Also with us this evening from Sarcoma UK are Emma, Louisa and me, Enda. Don't hesitate to get in touch anytime throughout the evening. If you need anything, you can reach us with the chat function. So some of you will have taken part in Zoom meetings before, and some of you may have taken part in webinars. The basic things to know are that we, the hosts and panelists, we can't hear you and we can't see you. But if you'd like to ask a question, there are two ways to do it. First one is type a question into the Q&A box, which is at the bottom of your screen, and we'll see it and we'll put that to the panelists a little later. The second way is you can raise your hand. So that's another little button at the bottom of your screen. So I see one person has their hand up already. We'll come to you in a moment. Okay, so we are going to go to Helen shortly and she'll talk a little bit about the type of questions that we can take, but we are going to leave about 15 minutes at the end for questions. First of all, I'd like to introduce you to the wonderful panel we have tonight. So we have Dr. Charlotte Benson, who is the consultant medical oncologist at the Royal Marsden. Dr. Benson specialises in the treatment of soft tissue sarcoma and GIST. And a few years ago, a question about hormone replacement therapy from a caller to the Sarcoma Support line prompted Charlotte, along with Sarcoma UK's Sam Hackett, Dr. Malie Fernando and Dr. Sarah Pratap, to study differences in practices in the UK. So we're delighted to have her expertise this evening. Then we have Karen Delin, who was diagnosed with sarcoma in 2006 and not long after set up the London Sarcoma Support Group. Karen has also been chair of the Sarcoma UK Board of Trustees and remains very closely connected to us, not least because her daughter Emma, who's also here, is our community fundraising officer. And Emma is here to help in any way this evening too. Do we have Emma McCloskey? We do indeed. Emma, we're delighted to have, has also been a sarcoma patient, is also a support group leader and a frequent fundraiser for Sarcoma UK. She was behind the superb blog dizzytix.com, which she used to write very movingly about her treatment for sarcoma. And she's currently busy helping us get ready for the final event in this 10-year anniversary of Sarcoma UK, the Glitter Ball, which will happen, we hope, in March 2022. So delighted to have her here. Finally, we have Dr. Beatrice Seddon, who is a consultant clinical oncologist of the Sarcoma Unit, University College Hospitals Foundation Trust, specializing exclusively in the management, chemotherapy, radiotherapy of soft tissue and bone sarcomas. She currently lectures and teaches on the management of sarcomas and is actively involved in clinical research projects in this area. We are extremely grateful to have this wonderful panel with us tonight. I'm now going to hand over to my colleague, Helen, who is going to take us through the rest of the evening. Helen.
Thanks, Enda. So it's lovely to have our panel here, and obviously those of you joining us from home. We do have a number of questions that we're going to put to the panel and just have a general informal discussion. So if there are any questions, I apologise, my Zoom kicked me out for a minute, but I'm back, so I'm sure Enda has covered all of that. So firstly, Karen, if I can come to you first, obviously you're a lady that has been diagnosed with sarcoma previously. Can you tell us a little bit about your experience and anything in particular that you think will help those people joining us tonight?
Yes, that's fine. So my experience with sarcoma started with one of those times where you weren't suspected of cancer. I was expected, I knew I had a fibroid, so I went in for surgery for a fibroid, and whoops, it was cancer, and it was a sarcoma. So I came into finding out my diagnosis in a roundabout way. From my experience, I think the important things that I have found through, it's now over 15 years, I think my experience is just to ensure that you're being seen at a sarcoma specialist centre. Particularly with gynaecological, you're often, you start your journey through a gynaecologist, and my experience is how critical it is to be at a sarcoma specialist centre. So to encourage people to have their care transferred, ensure that they're under a sarcoma centre, and it could be that there's joint care, and maintain the contact with the gynaecologist. But it's the importance is to be within a sarcoma centre.
Absolutely, thanks, Karen. And Dr. Benson, sometimes we have issues with ladies that unfortunately, are with the gynaecology centres and not specifically with the sarcoma teams. How do you think we can perhaps improve that collaboration between the two and make sure that ladies are being discussed by your teams?
Well, at the Marsden, we have a big catchment area. So we have gynae patients who are referred to us all through sort of the southeast. And one of the things we've really worked on is good communication between our team and the gynaecology teams locally. So we quite often have informal communication through email or telephone calls. And we really encourage a low bar for referral to our sarcoma MDT, which is like the multidisciplinary meeting, where we can discuss individual patients, look at their scan and try to advise on management. And as much as possible, we try and encourage that we see patients face-to-face or for a telephone call at the Marsden so that we can help best to advise on the next steps.
Right. And as with many of the cases like Karen's, unfortunately, ladies are treated for what are thought to be fibroids to begin with. Dr. Seddon, is there anything that we could be saying to ladies or anything in particular that we need to be looking out for when ladies are being treated for fibroids that could potentially tell us that they may lead to a sarcoma diagnosis? Or is it literally that we do need to wait for that histology?
I think that this is it's a tricky area, and I guess the first thing to say that is that many women have fibroids and very few end up having a leiomyosarcoma, and so this is infrequent. I think the difficulty with assessing fibroids, certainly on imaging, is that there are not clear features which say that this is definitely cancer or leiomyosarcoma rather than just a big degenerating fibroid. And so a fibroid can look quite alarming, but it isn't cancerous at all. I mean, classically, the history for a tumour is of a growing fibroid, and that should be raising alarm bells. Or clearly, if a fibroid is growing and actually looks like it's growing out through the uterine wall, that would be potentially another thing which would make you concerned. But I think probably the crucial thing is a growing fibroid should be of concern.
Thank you. And obviously we worked hard with the Royal College of Gynaecologists with the guidance on morcellation a couple of years ago. And Dr. Benson, what was the importance of that? Why was it really important for us to make sure that potential ladies that were having treatment for fibroids weren't going down the routes of morcellation for their treatment?
So sort of morcellation is then the term for using a specific machine called a morcellator, which breaks up the fibroids into a sort of small bag. And what was thought to be the advantage of that was it was for women having surgery for fibroids. Instead of having a large cut through their tummy or a big scar, they could have the surgery done laparoscopically or by keyhole. And whilst that potentially is a safe operation for patients with genuine fibroids, the concern is, as Beatrice was saying, that many patients with leiomyosarcoma are not diagnosed before surgery, and the worry about breaking up a uterine sarcoma and morcellating or breaking it up into small pieces is there's a very great risk of spread throughout the abdominal cavity. And so now this concern has been raised. There are specific guidelines on the Royal College of Obstetrician and Gynaecology website saying that it's really clear that if you're being offered morcellation, to discuss it carefully with the gynaecologist beforehand and to be sure that it's a benign fibroid they're dealing with and not a uterine sarcoma.
That's great, thank you. And Emma, in your role as a support group leader, is this something that's come up with any of the people that attend your support group?
No, it's not something that's come up with. We run the Merseyside and Cheshire support group, and we don't have a lot of people with sarcomas that are specific to women. However, we have started to hold Zooms and we have started to get more and more people. So we've had a few new people recently, so we're just waiting to hear their stories, but it's not something it's not something that's talked about a lot, and it's not something that comes up a lot. When I mentioned, because we've got our support group this evening, when I've mentioned that I was coming here tonight, people were interested, because I don't think they've ever really thought that there was a difference between male and female from a sarcoma perspective. But it's not something that's come up with any of our patients.
Okay, thanks, Emma. And Karen, you've recently set up a new email support group specifically for ladies with gynaecological sarcoma. Would you like to just update us on how that's working, or how people can help attend that or join that?
Yes. So there was an email support group, which unfortunately had to close down. The format had to close down. So we acknowledge that actually the ladies that were on the group benefited and gained a lot of support, because although there's other mediums to have support for a gynae sarcoma, you can and sometimes want to discuss things that are very personal, as it's a gynecological cancer. So we always felt that we needed a little bit of a buffered support group, a private one. So this support group is run by an email platform called Groups.io, and anyone can join that has a gynae sarcoma. I will try to post the information through the chat during the question section, but otherwise there'll be information also on Sarcoma UK website, but I also can have anyone email me directly, and I'll put that detail on, and you just register to be part of the group, and we could admit you. The group doesn't have a huge number of emails, it's not onerous, but when people do need the support or need to ask special questions, there's, a group of people that could understand what's happening specific to gynae sarcomas and offer support and advice.
Can I just say that I have put that information in the chat now. Thank you.
Thank you, Enda.
Thanks, Enda. And so once people have been given a diagnosis of a gynecological sarcoma, for example, Dr. Seddon, what's the kind of main treatments that people can expect to receive? And is it standardized, or is it that obviously with a lot of the sarcomas we have to take people as individuals, because we know that they do different things in different people? And is that the same for the majority of the gynae sarcomas?
I guess the answer to that is it's it's a bit of both, in that clearly, you know, we have protocols and you know, in terms of how should we ideally treat people, but then you know, every patient is different, and so it's really important paying attention to the detail for that individual person and saying, you know, what is right for that person. I think for you know, what I can say is that for, you know, the vast majority of newly diagnosed gynae sarcomas that are just located within the pelvis, that there isn't spread elsewhere around the body, then we would expect those women to have surgery, which is usually hysterectomy plus or minus removal of the ovaries, and that, you know, that would be done by a gynae oncology team who would be liaising, as Charlotte said earlier, with the sarcoma team. So that there should be all the, you know, those women would be discussed in both MDTs, the gynae MDT and the sarcoma MDT, to make sure that best management is happening. And then once surgery has been done, I mean, you know, often actually the diagnosis doesn't get made until surgery, although increasingly gynecologists are calling us saying, you know, I've got somebody with a big uterine mass, we're concerned it might be a sarcoma, are we okay to go ahead with surgery for this patient? And so we would say yes, and then we would look at the resection histology, you know, the pathology that's been looked at in the lab for all of the details, so the type of the sarcoma, the extent, you know, has there been any spread in the pelvis, all of those details to make decisions about what might happen next. I guess the things that we might think about for additional treatments over and above surgery, we would think about radiotherapy, and that's certainly something I do as a clinical oncologist, and not, you know, we don't recommend radiotherapy for everyone, and it does tend to be, you know, to a degree it tends to be individualized. So, you know, for women who we feel will benefit from radiotherapy, because it can be beneficial, but equally it can, you know, any treatment has side effects, and so you want to be sure it's appropriate. We do, I guess, you know, the other treatment that we might think about is chemotherapy after surgery, although what I would say is that certainly for both ourselves at UCH and at the Marsden, because we have common treatment protocols that, you know, that we've come together to create, we don't routinely give what we call adjuvant chemo, which is chemo given after surgery, because although there's been a lot of thought about this and work done over the years, it hasn't really been possible to say that giving a course of chemotherapy after surgery, certainly for the high-grade gynae sarcomas, is a helpful thing, that it cures more people. So it tends not to be something that we use routinely.
That's great, thank you. And Dr. Benson, for those ladies that we do give the chemotherapy to, we kind of are still using, you know, drugs that we've been using for many years that do have quite toxic side effects. And from a woman's point of view, what sort of side effects can they bring about that ladies should be aware of?
So as Beatrice said, I think we don't routinely use chemotherapy immediately after surgery for women who've had a sarcoma, which is just confined to the uterus. And that's because clinical trials that have taken part in the past have not really shown any benefits. So we're very thoughtful before recommending chemotherapy. In terms of what, if you are being offered chemotherapy, the commonest drugs that would be used in a situation would probably be doxorubicin-based treatment and possibly gemcitabine-based treatment. Doxorubicin has a number of side effects. I think fatigue and low immune system are very common, and also hair loss, which is, of course, can be upsetting for many patients. If you have gemcitabine-based chemotherapy, sometimes you can avoid hair loss, but the tiredness and the immunosuppression are still a part of the treatment. The other thing I was going to add about your question to Beatrice about what happened when we first see patients is if patients have had surgery at another hospital which is not linked to one of the hospitals where Beatrice and I work, one of the most important things is asking one of our pathologists, a sarcoma pathologist, specifically to look at the pathology or the tissue that was removed at the time of surgery under the microscope. Because sometimes some key changes or key tests can be performed that really help us to individualize and choose the correct treatment for the patient.
That's great. And if we were to have somebody, obviously we have a number of people that come through to us on the support line, and we would say exactly the same thing to them. How would you advise if they were asking that question, but that still wasn't being done?
That's really difficult. I think these days, much more frequently, patients who are seeing a gynaecologist with a sarcoma are much more likely to be referred to a sarcoma centre. And I think that has improved in the last 10 years. So I think the message is getting out there, and Sarcoma UK have done a lot of good work to support this. I think it's really important as a patient to stand your ground, and you can get support from, say, your helpline at Sarcoma UK to ask specifically for a referral to a sarcoma centre. The other person that can be your friend is your general practitioner. Even if your GP has not had direct experience of sarcoma, they can also contact a sarcoma centre on your behalf if for some reason your hospital is not agreeing to refer you for review. And once you have been referred, as a matter of routine, then we would request the pathology to be sent from your hospital and also any scans and test results that you have had.
That's great, thank you. And obviously we've kind of been focusing on the gynaecological sarcomas here, but obviously ladies get all the other types of sarcomas as well. And for some of those, chemotherapy is the kind of first treatment that they receive. And so with those ladies, what are the main issues that they can get from those chemotherapies? And I'm thinking more of the bone sarcomas potentially. So maybe Dr. Seddon, you could answer this one for us. Because obviously the ladies that have treatments for Ewing sarcoma and osteosarcoma may get some side effects from their treatments that might be different.
I guess the important thing is that we're frequently treating young patients with osteosarcoma and Ewing sarcoma diagnoses. I'm also mindful of one of the comments in the chat actually about doxorubicin and ifosfamide for a retroperitoneal sarcoma, and of course, you know, with these intensive regimens in younger women, then the really important thing is the effect on fertility and also possible premature menopause. And so these kind of drugs can, so I'll do the two things separately. So these drugs can affect fertility. It, depending on the schedule, it's not necessarily irreversible, that a woman's periods can stop during chemotherapy, but that does not mean she is being rendered completely infertile, although that can happen, and the risk is higher the closer somebody is towards the menopause. So a young woman maybe in her teens and 20s would be less likely to be rendered infertile by chemotherapy than an older woman who's more maybe in her 30s and 40s. So so I guess that's an important thing to say. I think another important comment is that we're in a better position now than we ever have been to think about fertility preserving things that can be done, and whether that's that might be, obviously it's harder for women because you can't just go and do sperm banking like men can, which is really easy. But there are various things that can be done, such as ovarian stimulation, egg harvesting, I'm not the best person to talk about this in detail, but I think one of the challenges that we have for the bone sarcomas is that often these are aggressive tumours that require quick treatment, and so spending several weeks doing ovarian stimulation and egg harvesting may not be practical. Sometimes it is, and we can do that, and so it's important to be able to refer to or have a good relationship, for us in the hospital with our fertility experts, so that if we can arrange for women to be seen to have that discussion about what might be appropriate for them. I think the other thing to talk about is the effect that chemotherapy can have on hormonal production from the ovaries, and potentially putting women into a premature menopause, and that is something that can happen. And again, that's kind of more likely for women in their 40s who are closer towards the menopause, and that the chemo can just tip them over into having menopausal symptoms. And I think that's important to recognise, because I think menopause can have difficult and troubling symptoms which can really affect quality of life, and that can be a big thing, that not only are you dealing with your cancer and your chemotherapy, but you're dealing with menopausal symptoms. I think menopause is quite a hot topic this year. I say this just from reading ordinary things like the Radio Times and the number of programs that there are, and women, sort of high profile sort of women in the media who are talking about menopause and how it's poorly understood, and even now in this decade and in this year that women go through the menopause without themselves understanding what it is, and also without those around them understanding what it is. And so I think it's very important to recognise that. And of course, menopausal symptoms can be addressed with hormonal replacement therapy, in some circumstances, if that's appropriate for that particular person, which can help with difficult, troubling symptoms. And that may be important if somebody's already struggling with chemotherapy side effects, and menopause is just one thing too many.
Yeah, absolutely. And with the ladies that potentially aren't able to use HRT to help with their menopausal symptoms, Dr. Benson, is there anything else that we can give to ladies to help them through this time?
So we discussed this a lot in clinic, actually, and I've been very lucky to work with a brilliant nurse specialist called Alison Dunlop, who is usually has got a real font of information. And there's some very good websites out there, actually, with tips for managing menopausal side effects where you cannot have HRT. And I always remind patients that, of course, this is a lot of women in the UK, because often women with breast cancer find themselves in a similar situation. And so there's Menopause Matters and also NHS Choices are both very good websites. We've also found some patients have found acupuncture particularly helpful for hot flushes, although I appreciate that sometimes acupuncture is difficult to access. We're lucky enough at the Marsden to have an anaesthetist who does an acupuncture clinic, but she's very much in demand, and I think it's not routinely available on the NHS, but that can also be helpful. I think there's some evidence with that using sort of yoga and exercise and even mindfulness can be very helpful. And I totally agree with Beatrice. For some women, that's just adding the menopause on top of everything else they're going through can be very difficult, and it's really important to recognise it. And of course, there are dedicated menopause clinics, although they're very much in demand, and we do refer to them in patients where it's been particularly difficult to manage.
Right, and like you say, Dr. Seddon, this can just tip people over the edge sometimes. And do you think that we have enough psychological support for our sarcoma patients who potentially need to talk those things through? Do you think that there's enough out there for ladies in that situation?
I think I would say I'm probably not the best person to answer that, in that's probably more, that's more of a sort of consumer question, because I can say yes, we do have, we do have resources, we do have counselling and stuff, but it's really the person who's on the receiving end, who's living through it, whether they feel that they can get, I guess, sarcoma specific support, but actually also, these very specific issues, sort of relating to, as we said, fertility, menopausal symptoms, and I think that's I think that's always a challenge for sarcoma patients, that can you get, because of the heterogeneity of the whole sarcoma population, which Karen was touching on sort of earlier, that there's all sorts of different sarcomas in different parts of the body and different subtypes, and so trying to find the help that's specific for you and your particular sarcoma and your particular problems, can be sort of quite challenging. So while I like to think that we've got good support, as I said, I don't feel in the best position to actually make that claim, although I hope it's true.
Okay, and so Emma, perhaps first, is this something that comes up in your support group, psychological support and access to it?
Yeah, I think, just speaking about my experience, I was 29 when I was diagnosed with my sarcoma. So I had a 7.5 pound tumour removed from my right thigh. About 3 months after, when my scars had healed, I was having radiotherapy. So before I started radiotherapy, my consultant did ask, did I want to investigate potentially freezing some of my eggs? Because my scar went from hip to knee, the radiotherapy was going to go quite high and it may affect my fertility. Now, being someone that has said since I was a child I didn't want children, I found it I was quite shocked, because I've always been in control of that decision, as in I don't want my own children. But then all of a sudden it became, oh, this is actually an issue. I made a very, very quick decision of, I'll deal with that later if I change my mind or whatever. But I didn't really get any counselling or support or anything to make sure I was making the right decision. At that point, it was, this tumour was huge. I know it can spread. I just want to stay alive. So if I can start radiotherapy on Monday and make my decision, I will go with that, rather than actually let's sit back and think about it, because this decision could then be taken from my hands, which then becomes a different scenario. So from I don't know, is it available? Probably. Was I offered it, personally speaking? No. And I do know that there are other people, other patients, that haven't necessarily been offered it. I have heard, talking about menopause, that some chemotherapies can bring on early menopause. I was 30 when I had chemotherapy, but no one's ever really discussed that with me. So I've learned a lot from being on here tonight about that. But yeah, all my support and advice has all been based around sarcomas and nothing to do with anything that I may experience as a woman as a result of the treatments that I've had.
Okay, so potentially that is something that we as a sarcoma community really need to perhaps look a little bit more into and find out what the experiences are, because we also know that experiences can be different depending on where you are and which team you're with. And Karen, would you say perhaps that's the same thing with the people that attend your support group?
Yeah, for the support group, I think we get a huge mix. So we haven't had anyone that had needed to consider fertility treatments. I think one person, it was discussed, but they didn't want it. But so I don't have the experience of hearing what someone's actually gone through to obtain and undergo fertility treatment. Menopause is often discussed, and especially obviously in the gynae group, but it's often discussed because of either the treatments and with surgical menopause through the gynae surgeries that people have had to have. It is a hot topic for us, and sometimes it is sharing that information, sharing those websites, like you mentioned, Charlotte, about these different websites that are available. It's that collective support of sharing information and sharing advice of how to access some treatments that aren't hormone based. So that's been a really huge wealth of information for people. I mean, for myself, I underwent quite a few years of having aromatase inhibitors to knock out all my hormones. And because my gynaecological was hormone sensitive, which that was my choice, and I'm pleased I did the treatment. But for me, it felt like I was going into deeper menopause. So I needed to sort of deal with menopause on 2 levels. And that was fine. I gained a lot of support, and I had a lot of information given to me from the medical team. So that worked, absolutely fine. And I've been able to share that information with other people, but it is a collective of sharing information.
Absolutely. Thanks, Karen. And Karen mentioned there, Dr. Benson, about the use of hormones with some of the gynecological sarcomas. And I know you and Sam did a piece of work about that. What sort of advice, when is it useful to get hormone testing on a gynaecosarcoma, and what does doing that actually allow us to then go on to do?
I think you could argue that for whatever type of gynaecosarcoma you're diagnosed with, I think it's always worth asking for the pathologist to check the estrogen and progesterone receptors, because potentially that can open up an avenue of treatment for you, just as Karen mentioned. When we talk about gynaecosarcomas, there's actually a number of different subtypes that can be included, and that includes something called endometrial stromal sarcoma, which is very often sensitive to female hormones. Sometimes when patients are diagnosed with this disease, if they've had their ovaries removed and the ovaries were producing estrogen previously, sometimes removal of the ovaries is enough because your estrogen levels will drop. But in other patients, we find that drugs like aromatase inhibitors, which further reduce the estrogen levels, can actually be a useful treatment. Just as Karen said, sometimes the aromatase inhibitors can actually magnify menopause type side effects. And so that's something where if you are on those drugs, it's really good to keep in touch with your clinical team and your clinical nurse specialists because we do have various tricks up our sleeve to help manage those side effects caused by the hormone lowering drugs. The other thing we didn't really talk about with menopause is it also has either women who've had their ovaries removed before menopause or who are on anti-hormone drugs. It can also have a lot of effects on cognitive function and how we're thinking and about how our brains are working. And we have had a number of women who've had hormone lowering treatments who found it actually difficult to concentrate or difficulty at work. So it's something that I think is becoming more recognised, and it's something that's always worth discussing with your team.
That's great, thank you. And obviously, there are other treatments out and around, and we often get questions on the support line around treatments like immunotherapy, for example. And for a lot of sarcomas, that isn't something that we can use at the moment. Is there anything from a gynae point of view, Dr. Benson, with immunotherapy that may be in the pipeline?
So I think immunotherapy is a very promising and exciting treatment, and probably people will have heard that it's already on the NHS for certain types of cancer like melanoma, lung cancer, or head and neck cancers. In sarcoma, it's very much under investigation. It's not routinely available on the NHS because it's not definitely a proven benefit yet, but it's something that people are actively looking into. And the way to try and access new treatments like immunotherapy is usually through the clinical trial route. So most people who are being seen at sarcoma centres, we're quite a small community, so that's nice that Beatrice and I work closely together and with all the other sarcoma specialists in the country. So we're all aware of what clinical trials are going on. And even if we don't have a trial available at our own centre, we know how to refer to another centre to help so that patients can access treatments such as immunotherapy.
That's great.
That might be a good time to just ask one of the questions that came in. Someone asked, what treatments through clinical trials are available if chemotherapy doesn't work? I don't know who would like to take that one.
I'll let you do that, Charlotte.
So there's a number of clinical trials running in looking for patients with soft tissue sarcoma. And to give you sort of a flavour of some of the trials that we've had open recently at the Marsden Hospital and other places, we have had clinical trial looking at the role of immunotherapy in patients with gynaecological and other sarcoma subtypes. And that trial has literally just closed, but we're now at the important analysis stage, and that will help us to learn whether that could be a helpful treatment for patients in the future. There are also trials looking at other drugs called tyrosine kinase inhibitors that inhibit new blood vessel formation, and we're looking to see whether they could be helpful in patients with uterine sarcomas. And also a big organisation called the EORTC, which is a big European organisation, have recently been running a trial trying to look at the role of maintenance treatment, so treatment after chemotherapy for patients who have gynaecological that has spread, to see whether that maintenance treatment might delay the time to disease relapse. So if you want to discuss clinical trials, it's always good to discuss it with your sarcoma oncologist. There's also a good website called clinicaltrials.gov, which tells you about all trials that are available for patients. I sit on what's called the NCRI Sarcoma CSG, and that also has a website which has a map of what trials are open. And Sarcoma UK, excuse me, also, I think, Helen, you quite often help to signpost patients to clinical trials. I think what's important to say is that they open and close quite quickly. A lot of the trials we take part in amongst a number of different hospitals and often a number of different countries. And so that you might see a trial advertised and it may be that trial is then closed, but then there may well be other things that could be suitable for you.
Thanks for that. There's another question from Kate, which is, I think Dr. Seddon, you might have referred to it. It's quite detailed, so maybe Kate calling the support line might be a good idea in this case. But the crux of it, I think, is I'd really like to understand more about how the menopause symptoms are not confused with my cancer symptoms. For example, I've stopped having periods during my chemo. Will they come back? Is it the cancer, the chemo, the menopause, or all three?
Well, I guess we did sort of we covered that a little bit earlier by saying that doxorubicin and ifosfamide undoubtedly can put people into the menopause, and so I suspect that that at least some of it is that it is true menopausal symptoms. I think are those symptoms cancer related? I think that's more difficult because we don't have that detail, and it's probably not appropriate on this call. But and I would agree. It sounds like it would be helpful to have a more detailed private discussion on the helpline to really sort of tease that out.
Sure. We have just one more. It's more of a comment, I think, really from someone. They said, I was 37 when I had radiotherapy for myxoid liposarcoma on my thigh. Me and my husband were not informed about the possibility of premature menopause. I pretty much went straight into menopause, but I thought it was depression. Eventually, I realized what was going on and I demanded to speak to a specialist. Unfortunately, it took a year to get on the right HRT and get sorted by the specialist. Some support at this time would have made it so much easier to understand. Instead, I was told it shouldn't have happened and had never happened before. I found it all very confusing. 2 years on, I feel like I'm getting there, but I just wish I had known more before the radiotherapy. So I guess maybe that's something that is maybe not uncommon.
Well, I think just to give a little bit of explanation about why that's happened, as to why does having radiotherapy on your thigh put you into the menopause. So it's really about if you give radiotherapy to a particular site, you're obviously directing radiotherapy there, but you can also get what's called internal scatter. And so the radiation, you can get low doses of radiation which are scattered beyond the site that you're treating. And so if you're treating the thigh, then you do need to think, for women, you need to think about scattered dose onto the pelvis if it's a tumor at the top of the thigh. And it should be something that, you know, that should be considered for all women having radiotherapy anywhere near the pelvis. You should be thinking, is this radiotherapy going to have scattered dose? Is that potentially going to affect either fertility, because it takes very low doses of radiation and scattered radiation to affect fertility, or is it, if it's slightly higher doses, is it going to affect, is it going to cause the menopause? Because obviously that's the hormonal production from the ovaries. And so it is, I think, as a clinical oncologist, radiotherapist, that, you know, that's something that one should be thinking about all the time when you're planning radiotherapy, and thinking, do I need to talk to this person about the possibility either of impact of radiation on fertility or menopause? So I mean, I think it's, you know, clearly it's difficult to comment on this person's case specifically, but you know, I guess it's you know, anyone having radiation near, you know, near the pelvis, that there should be consideration given to the impact on fertility and menopause, and that should be discussed with the patient.
Okay. Thank you very much. I think we are approaching the end. So just before I say goodbye and thank everyone, Helen, we are having a special Zoom on the 29th of July. Would you like to talk a little bit about that? Because it may be of interest to the people who are attending.
Absolutely. So Sam Carley and myself obviously run the Sarcoma UK support line. And so we have lots of interactions with different people on that. And one of the things that we've come across more recently, which we hadn't quite thought of before, and I'm not quite sure why, is that over the last kind of 18 months with the COVID restrictions, we've found that potentially loved ones of sarcoma patients who would normally attend clinic appointments with them have had less of an ability to do that because of restrictions. So we are opening up a Zoom a bit like this on the 29th of July for any loved ones, partners, spouses, children that may or may not normally take parents to clinic appointments, so that they can come along and ask us all those questions that they would normally want to ask the clinical team, to come along, and hopefully we'll be able to answer some of those for them. So anybody's welcome to come along, and if you want to send your questions in advance, that's great. But if not, just turn up and we will be there to help go through things with you.
That's great. Thank you so much. Actually, details of that, we haven't put them online yet, but when we do have them online, it'll be at sarcoma.org.uk/10 years. And I've got that link in the chat. In fact, you can find our entire program for Sarcoma Awareness Month, including the next 3 webinars over the next few weeks. And of course, everyone is welcome to join. I think if it's anything like tonight's one, they will be certainly not to be missed. I think all that's left for me to say is just that a recording of this will be available. We'll edit it and have it up at the same link in a couple of days' time. So please feel free to share that with anyone who couldn't make it tonight. I want to thank our panel again, Dr. Benson, Karen Delin, Emma McCloskey, and Dr. Seddon. And of course, our host, Helen Stradling, for looking after everything so well. Thank you very much to you for attending the first of our sessions. And hopefully we'll see you again shortly, next week perhaps. Thank you very much, everyone.
Thank you.
Thank you.
Thanks. Bye.
Bye-bye.
Thank you.